Okay, in the lateral radiograph, enlarged epiglottis, thumb sign, this thumb sign, epiglottic fold thick and convex superiorly, ballooning of the hypopharynx. Frontal radiograph may see symmetric subglottic narrowing. In the CT, it is very rare to reach to this. You see this rarely see phlegmon or abscess. Okay, and this secondary to epiglottitis, but you had to say the epiglottitis. Yeah. Okay. Oh yeah. Okay. Abscess. Okay. Regarding the parotid, yeah, it can be an abscess, but multiple abscesses. The patient in this, when I tell you HIV lymphobacterial cyst, linked to lymphobacterial cyst, the abscess, the wall of the abscess should have well-defined thick wall, thick smooth wall to call it an abscess. The cysts, generally, all the cysts can have pseudo-marginal enhancement because of the enhancement of the surrounding structures. But the abscess, to call something abscess, the abscess, either there is solid component and there is internal cystic component, this internal breaking down, and there is ongoing abscess formation, or there is an abscess, or this should be well defined with well-defined wall, not pseudo wall, pseudo enhancement. Understand? I hope this is clear. Just let me open, turn back to this case. Okay. This enhancement is not true enhancement. This enhancement of the surrounding parenchyma. Okay. I want to show you the yeah. This enhancement is not true enhancement. This is not true enhancement. Okay. This is related to the parenchyma itself. You see this, which surrounds this cyst. Okay. But in the abscess, you should find a wall to call it an abscess. Okay. I hope this is clear. Okay. Any other question regarding this case? Okay. Okay. These other examples for epiglottitis. This is in the CT. This in the X-ray. Okay. The differential omega-shaped epiglottis is an anomaly, hemophilia with local bleeding, angioneurotic edema. This is Steven Johnson syndrome, something related to the, I think, the gynecological, epiglottic cyst, okay, and epiglottic cyst and corrosive burns. Okay. Okay, this is the next case. What do you think? Are you sure? Who said group? This is laryngeal cyst. I think group doesn't present in this way. Okay, group should be from symmetrical and from both sides. When it is comes from one side, it should be other laryngeal cyst or hemangioma or like that. This was fluid attenuation, non-enhancing lesion, non-enhancing in the CT, non-enhancing rounded lesion, well-defined and attaining fluid attenuation. Group should be coming like that, okay? But here it comes from one side, so it is not group. Okay, I hope this is clear. Yeah. So this in this case it is cyst. Okay, could be hemangioma. Yeah, it is difficult to call it only cyst. You have to mention the other differential. The other differential are accepted, the hemangioma, but this is at the level of the larynx. Okay, is that clear? You have to mention the other differential, but this is not group. It's not group. Group should come from here and here. Okay, but here this from one side. So hemangioma is a, for me, cyst, laryngeal cyst, and hemangioma. Okay. Other differential: thyroglossal duct cyst, dermoid cyst, branchial cleft cyst, hemangioma, and papilloma. Okay, these are other differential. I'm sorry. Thyroglossal cyst, you have to ask the patient to just protrude his tongue, and it is a bit higher level. Dermoid cyst, this is still cyst. The branchial cleft cyst, the different types of the branchial cleft, type 3 can present near to this region. And the hemangioma, we mentioned the hemangioma and the papilloma because still soft tissue. Okay, here it is. This is the cyst. This is laryngeal cyst. Okay, epiglottic cyst. These are the examples for thyroglossal cyst near here to the mouth floor. Okay, and you can ask the patient to protrude his tongue, especially in the ultrasound. You will find you put the probe and ask the patient to protrude his tongue like that. It will move. So it is a thyroglossal cyst. Here, this third branchial cleft cyst in its vicinity, and here it is a very important case. I wish I hide this side. So what is the problem now? Okay, great. Thank you. This pre-vertebral abscess, retropharyngeal abscess, you will see the main parameter for you is the vertebra. This vertebra. It is more than these vertebra, the AB diameter of this vertebra. So this is the retro. This is a parameter for retropharyngeal abscess. Okay, here it is in the CT, and this is the spaces, which is very important. Okay, this is just brief. This is diagram for the spaces. Keep it in your mind. Okay, this is a masticator space. The parapharyngeal spaces. This is a perivertebral spaces. Just to consider, this is a brief diagram, just for your knowledge. Okay, just to remind. I know that you know this well, but consider it as a reference when you do need it. Okay, next case. What's your impression? No, no. Yes, great. Yeah, here it is. This zone. Subperiosteal abscess comes from the most common infection from the ethmoiditis. Okay. Subperiosteal abscess and ethmoid, the most common reason is ethmoid sinusitis. It can have intracranial extension, which is a bit rare, but can happen. Okay. This is considered, can be easily managed when you diagnose it, when you see it and interpret it correctly. This is very helpful. Very helpful. Okay. Okay. Sure. Yeah. Here it is. You will find this. Compare between both sides. These lacrimal glands, and here it is. This is a subperiosteal abscess. This is a subperiosteal abscess. Okay. I hope this is clear. This collection, subperiosteum, and go. This coil can go everywhere. And here it is the inflammation, the sinusitis. Okay. Thank you. Next case. What's your impression? No, I will tell you the keywords of this case. The patient is young patient, around 7 to 8 years old. What is the most common mass? If I rule out hemangioma and the muscle is involved and indistinct, what is the most common? Yeah, true. Consider it rhabdomyosarcoma until proved otherwise. Okay? Don't dismiss. Don't dismiss. The muscle is indistinct, so tell the examiner that intraconal muscle is distinct. I have to rule out rhabdomyosarcoma. So I wanted to review the patient history because hemangioma at that age should regress. Hemangioma is not flaring. No, it regress. Okay, so I wanted to review the patient history. Okay. Lymphoma, yeah, lymphoma, but look, lymphoma can present anywhere, but the lymphoma is bit cellular. So in the MRI, it should be more hyper intense in the T1 because it is cellular. Okay, it is cellular, and in the post contrast, the enhancement should be more homogeneous. Okay, this is for the lymphoma. Okay, rhabdomyosarcoma, as I think we explained it in the orbit before, but there is proptosis, involvement of the muscles, the most common tumor, the most common malignancy in that age. So it should be your first differential, and you know that sarcoma, rhabdomyosarcoma has a good prognosis. By the way, has a good prognosis. Okay. Okay. Next case. Not typical for meningioma. Meningioma, tram track appearance around the nerve. Meningioma. Okay. Okay, great. Thank you. This is hemangioma, and I have no words. You should not say any other things except that. Okay. Okay, infantile hemangioma. Okay. Next case. I showed it to you before in one of the differential. I hope you still remember it. At that site, not an abscess, not cyroglossal cyst. What the other differential? Not laryngeal cyst. No, I told you that. Yeah, great, Dr. Said. Great. Yeah, great. Yeah, this is the fourth branchial cleft cyst. Okay, this cyst in that region. Where is the first type? Where is the first type? First branchial cleft cyst. Huh? Yeah, retroauricular. Yeah, great. Okay. Okay, his sinus tract extends from the apex of the piriform sinus to lower anterior neck after barium swallow. His contrast enhanced best demonstrates phlegmon or abscess or in or adjacent to anterior left thyroid lobe. CT after barium swallow best identifies sinus tract. Direct injection of fistula best demonstrates course of fistula. Okay. Okay. Yep. Again. I repeated it again. Yeah. Yeah. If you dismiss There is no mercy in the exam. There is no mercy. This cannot be dismissed in the exam. Okay. Retropharyngeal abscess again. Okay. Other pharyngeal perforation, trauma, foreign body. Okay, this is the most important point. Normally, this space is not greater than the EB dimension of the cervical vertebrae, and the radiograph should be repeated with the neck fully extended. If you have still it is questionable. Don't, if you suspected, don't leave the patient go. Ask the help of a senior radiologist. But if you suspect it, please don't leave the patient to go. Okay. Okay, I finished the cases just here. The leveling of the cervical lymph nodes, you know, the level 1, just you are drawing. Just let me. Okay, if we have the neck here, and here it is this submandibular gland. Draw a line anterior to it. This one. Okay, type 1. ماشي, type 1. Posterior to it, type 2. Get it level 2. Okay, that's clear or not? Here, between in this region, this level 1A. This between the two bellies of digastric muscle. Rather than that, level 1B. Okay. On the other hand, starting from here to the level of the hyoid bone, it is 2A. 2. Below the hyoid, 3. And like that. Okay. If we have vessels here, how we would differentiate between type A and the A and the B? We have here this circle. Okay. Here, A. Here, B. Okay. Clear? Posterior triangle, posterior to sternocleidomastoid, this type V. Okay. I hope this is clear. Type 2 from type 1 anterior to submandibular gland, type 2 until all type 2 down distal to the hyoid bone, then the cricoid, this is type cricoid type, and then to the sternum, to the clavicle is the type 4. Posterior to sternocleidomastoid, it is type 5. Anterior, perilaryngeal, peritracheal, called in the Cancer Institute Delphian lymph nodes, this type 6. I hope this is clear. If you want me to explain more, yeah. Okay. I hope this is clear. Okay. Just to fulfill my promise to one of our candidates here, this is you will find this presentation, this is the leveling in the details, but just I want you just briefly for your knowledge and the background, follow what I told you. Okay. Thyroid nodules. Look, this classification, what I tell you, is not the best classification, but this is what is done in the UK. Okay. It is above your level, but I have to tell you that because you will, this is for your experience in UK. We have here the U classification. Most of the world and US is the lead for everything. They follow TIRADS or ACR or like that. So this is not done unless except in the UK. Nobody follow this except in UK. Okay. It is very for me because I presented the head and neck MDT and still not so convinced of this system. Okay. Okay. Let me. This is a U1. is a U2, U3, U4. U3 is the equivocal. Starting from U3, you will send this patient for fine needle. Before U3, no need for fine needle. And the follow-up, I just to decide follow-up or just leave the patient to go home if not symptomatic. So in the MDT, you go to the MDT to say U3 or above or below U3. Okay, this is the most important. So in the U1, no nodules. U2, hyperechoic. This is hyperechoic node, isoechoic, cystic changes. This is the U1. There is no nodules. U2, you see this hyperechoic, cystic changes, colloid cyst, heterogeneous or like spongiform appearance. There is rim of calcifications. The calcification, if microcalcification, it is malignant. If large calcifications, you can, it is our shell calcification, it is benign. Vascularity is marginal vascularity. Okay, this type. U3 called indeterminate. You will send this patient who find it solid, homogeneous, marked hyperechoic, solid nodules, and this halo. This means that this halo, this compressed surrounding soft tissue, or heterogeneous like that, hypoechoic with equivocal echogenic foci and the internal vascularity. This is U3. U4 is suspicious, highly suspicious, and this is these lesions hypoechoic, and disrupted peripheral calcification. You see this calcification here, disrupted from the at this side. You see in the T2, I will show you T2. You see the calcification is smooth and go everywhere. Okay, smooth calcifications, but here this is disrupted from here and from here. Okay, and lobulated margins like that. Last type is sure malignant microcalcifications. Okay, and there is calcifications in the lymph node is keeping away. I want to listen to an answer here. If there is calcification of the lymph nodes, papillary cell carcinoma. Great. Papillary cell carcinoma. Okay. This calcification, microcalcification, irregular, heterogeneous, internal vascularity. So all of these keep with type 4. Any questions?